So hi, I saw that some people have just joined us, and I believe there are, so most of us are from the 6 High School of Economics side, but some of people may come from different locations. So I see some names maybe of people who are from other sides. Yeah, so I guess that we can start. So once again, Moon, thanks for joining us today. It's really a pleasure to meet you and to hear your talk. Yeah, we really appreciate this, that you could participate. Yeah, so let me say a few words about you. So Monmonde Chowdhury, she's an assistant professor of interactive computing at Georgia Tech. And she is a pioneer of studying mental health based on digital traces data. I guess that it's for almost 10 years now, right? You're using various data sources from various social media platforms to study well-being, to figure out how to do this ethically, which is also really, really important. So if you guys want to get a sense of what is the state of the art in this field, you should just visit Monmon's site, and you will just get a really cool picture of what's going on in this area. So we are really looking forward to your talk. Thanks a lot. I think that we can start. So the floor is yours.
Thank you very much, Lisa. I really appreciate the invitation. So let me see if I can share my slides now.
Yeah, you should be able to share them.
Can someone confirm if you see the slideshow and if you see like the presenter view or the slideshow?
Yeah,
Right?
everything is fine. Yeah.
Okay, great. Thanks. All right. So, well, hello, everyone. I really appreciate you joining me for this event today. I heard from Lisa that it's the last day of the summer school, and I'm deeply grateful that you could stick around for this last event. So it's my absolute pleasure and honor to have the opportunity to speak with you today. And what I'm going to do is I'm going to review some of the work that we have been doing at the intersection of social media and mental health over the past few years. Basically thinking about opportunities, what we have seen to have worked, what we have seen to be missing or not worked. And then I'll discuss a couple of case studies that use synergistic and critically leaning collaborative action research approaches to allow us to reflect on how can we go about filling existing gaps. And then I'm going to conclude with some directions for future research and challenges that still remain unaddressed, but which will be really critical for us to see that these kind of new data sources and these kinds of approaches can be useful in real world contexts. Before I get started, I have a content warning. This presentation does have some descriptions of serious mental illnesses, suicidal ideation, self-harm, and so on. All right, so we all know that powered by the data and the digital traces that people are leaving behind on different online and social media platforms, over the last year and decade and a half, we have seen a new field emerge, and that's what the summer school is about. That is the field of computational social science. And this field has made many significant strides into improving our understanding of various kinds of social phenomena. So for instance, these data can now be used to provide new ways to measure our social interactions, our moods and emotions, our political ideologies, our collective action, and most relevantly for this talk, our health and well-being. So in the initial part of this talk, I will take the opportunity to share with you some of the highlights of the work that my collaborators, my students, and myself, we have been conducting over the past couple years that would showcase the computational use of social media data for mental health. And the way I'm going to structure this conversation is using two different angles. The first angle is that, in the past year, we all have been experiencing a number of different crisis events in our lives. And this obviously includes the still ongoing COVID-19 pandemic. So the examples I'm going to be highlighting here, they would speak to some of these crisis events and sort of the role that social media has provided us in helping understand mental health in these trying times. And then the second angle that I'm going to structure this conversation on is using the social ecological model, which is a widely validated and widely used conceptual framework in the public health and other social science fields. All right, so let's focus on the individual level. Focusing on the individual level, one thing that we note that, if we talk about crisis in in today's digital age, they're frequently accompanied by obviously useful information that you get from the internet, but also misleading information that circulates widely on the web. So while we have a lot of efforts to understand the direct impacts that crisis events have on people, a considerable number of people are also impacted indirectly because of their exposure to these harmful misinformation. And COVID-19 is no exception to this phenomena. So in this work, we wanted to study how exposure to misinformation, as could be indicated by people's sharing behaviors on social media, that affects their psychological well-being. So to answer that question, we conducted a large-scale observational study that used a propensity score matching causal framework, and it used about 80 million Twitter postings that were made by close to 77,000 Twitter users during the first 18 months of this pandemic. What did we find? We found that people who shared COVID-19 misinformation, they actually experienced approximately 2 times additional increase in anxiety when we compared with similar individuals who did not share misinformation on COVID on Twitter. But what was even more revealing to us was the socio-demographic differences in this increase. We found that people who identified as females, racial minorities, and individuals who had a lower level of education in the US, they experienced a disproportionately higher increase in anxiety when compared to other users. So what this study does, it adds new kind of evidence to efforts of social media platforms to moderate misinformation around a number of topics, but also evidence that could help us curb some of its negative or adverse impacts on our psychological well-being. And it makes us think about how crisis events can be better managed by different organizations or governments by allocating resources for people's psychological well-being as well who are vulnerable to misinformation. All right, so now let us move on to the granularity of communities using the social ecological model. So here we focused on a particular type of community that is called situated communities, and these are college campuses in this context. And the crisis events we are looking at in this study were gun violence incidents such as mass shootings, which unfortunately have been common in many universities in the US in the past several years. So what we wanted to do here is we wanted to leverage social media data, and we proposed new kinds of computational techniques so that we could quantify and examine stress responses following gun violence incidents on college campuses. We focused on 12 incidents of gun violence that happened on 12 different campuses in the US over a 5-year period. And then we collected social media data in the form of Reddit postings that were shared on the subreddits corresponding to these 12 schools. After that, we developed some interrupted time series based analysis based methods. And what we found using those methods is that if you look at a 30-day period following these gun violence incidents, there are amplified stress levels following these incidents, which often deviate from sort of the usual stress patterns that you would see on campuses. But it was not just this increase in stress that we saw, which kind of makes sense, it's intuitive and it's expected. But what was less expected was the linguistic change that characterized these changes in stress. So for instance, we found that after these gun violence incidents, people had a change in the kinds of words that they used in postings that were indicative of high stress. These had reduced cognition, they expressed higher self preoccupation, and then there were more death related conversations in these postings. So, stress contributes to, it constitutes a persistent well-being challenge, right, to many college students across the world. And it impacts their personal, social, and academic life. But when you have violent incidents on campuses, these events aggravate student stress because, there is fear, there is trauma that is induced as a result. And therefore, a lot of times these violent incidents impact a much larger set of people in these situated communities than sort of the direct victims. So what this study allowed us to do is it allowed us to kind of rethink how these campuses, these situated communities, can think about responding to these kinds of crises on campus, and rethink intervention and policy approaches that can connect particularly vulnerable groups of people on these campuses to help. All right, and then at the level of at the granularity of the population, again, we return to the COVID-19 pandemic context, and this was a study that was done early on in the pandemic in order to understand what kind of mental health impacts is the pandemic having on people. So one thing that we understand pretty well is that the pandemic disrupted a lot of aspects of our lives, whether it's personal or collective. And but what we didn't quite understand well is the impact that the pandemic is having on people's mental health. So we wanted to gather population level insights about people's psychosocial concerns during sort of this early part of the pandemic by using social media data. So for this, we collected about 60 million Twitter postings that were geolocated in the United States over a 2-month period between mid of March and mid of May of last year, 2020. And then we compared these trends with an equal volume of Twitter postings, which were shared in the year before, in 2019, during those 2 months as well, but when there was no pandemic raging in the world. So we found that, basically across the board, any kind of psychosocial or mental health expression you see, whether it's depression, anxiety, stress, or suicidal ideation, across the board, these trends increased, and they were much elevated in 2020 during the pandemic compared to what it used to be in 2019, the year before. But at the same time, what we saw that there was a steady decline and eventual plateauing of these trends. This could be indicative of habituation or people sort of settling into a new normal. And then we looked at the language that characterized these trends, and what we found is that people were using social media to meet their unique needs during the pandemic. For instance, people expressed concerns regarding their personal and professional challenges, access to healthcare, any kind of precautionary measures that people had to follow, such as social distancing or quarantining, and general pandemic-related awareness. And people extensively use social media also for seeking support or engaging in sort of candid conversations about mental health during this time. So what the study tells us is, there's a lot of potential to provide mental health insights to sort of crisis rehabilitation workers or stakeholders or policymakers and the government, so that they can plan and implement measures that can take care of this sort of twin epidemic that is unfolding in the world right now, aside from sort of the direct outcomes of the COVID-19 pandemic in terms of infections or deaths, but also sort of this probably longer term epidemic that is also happening in the world around declined mental health and what needs to be done in the months and years forward to address that issue. All right, so hopefully this gives you a glimpse of the potential that lies in using social media data in order to tackle some of the challenges that comes with understanding mental health, and the insights that we could gather from social media data and by using computational approaches. But the question is, you might be wondering, so what is sort of the next step in this line of work, right? Are we ready for real world deployment or use of these types of digital data traces, or use of these models in the real world? And given that these haven't quite happened so far, the question is, what is preventing us from pursuing these directions, right? That's what we're going to talk about next. So I would note that there are three issues that we need to pay attention to, and address before sort of we can realize the potential of these data sources and algorithmic insights. And these are agency and power, unintended negative consequences, and ethics. So across the board, across these three issues, there are a number of questions that we have to confront first. So for instance, logistical aspects of doing these kind of studies, like, how do you consent people? What kind of provisions we should have in place to avoid, to prevent adverse outcomes, because, we are dealing with a very sensitive topic like mental health. Then there are questions of how do we protect a vulnerable population who is subject to this research. And I would note that a lot of the populations are very already vulnerable. They are marginalized in the society. And what we want to do is for technology to support those vulnerable people instead of alienating them. And then and then there are questions that comes up about the researchers like ourselves as well. Sort of, what is the social and moral responsibility that we have in minimizing harms? Because, to be honest, I mean, while we want these algorithms and these data to be useful for real world use, there are also risks of harm. And what we need to do is to think about our moral and social responsibilities that can reduce those harms. There are a lot of questions that remain unanswered along those lines as well. But ultimately, what these questions point to is that there is a need for consideration of these three things, such as agency and power, unintended negative consequences, and ethics, as sort of part of the research process itself, instead of an afterthought. So, what I'm going to do in the remainder of this talk is that I'm going to present a theoretical lens that we can adopt as computational social scientists to make our research sort of both rigorous and ethical, and at the same time practical and actionable. So this particular research lens is called the action research framework. So action research is essentially a philosophy. It's not just a framework. It's a philosophy. You can think of it as a methodology. And it's actually generally applied in the qualitative social science field. So some of you may be aware of that. And it is pretty old. It was coined by Kurt Lewin in 1944, so a long time ago. And what is excellent strength of this approach is that it seeks transformative change through in an iterative fashion through the simultaneous process of taking action as well as doing research. And these are kind of linked together by critical reflection. So essentially, you can think of this framework as sort of a spiral of steps. And each of those steps is composed of, a phase of planning, a phase of action, and then fact finding about the result of what happens when you take that action. So while this is common in the qualitative social sciences, actually, when we talk about computational research, we actually don't have any formal guidance on how we can go about applying this paradigm. So what I'm going to do is I'm going to highlight two case studies and showcase one example of how we had adopted this framework as a way to collaborate on a shared goal and mission between our team and various stakeholders in mental health in order to have better potential for translation of these outcomes and algorithms in the real world. So the two case studies are again going to use the social ecological model. So one of them on the left is going to be at the individual level, and the other is going to be at the population level. And I'll talk about the different types of organizations that we have partnered with for this purpose. So the first case study is a collaboration that has been ongoing for the last 4 years with a big health system based out of New York in the US, and that's called Northwell Health. They're engaged in many cutting edge research projects around kind of bringing treatment, new novel kinds of treatment to people struggling with mental illness. But at the same time, they also do extensive research on what those cutting edge approaches could be. So our project, our collaborative project is called Thrive. And the idea here is to see what potential lies when we can gather voluntarily shared social media and other web data of patients, and whether that can allow us to think about new kinds of clinical tools and how those algorithmic insights that you can gather from these data sources can support clinical decision making, whether it's improving treatment, or empowering the patient better to be knowledgeable and actionable towards their mental health. So here we are actually investigating a number of different questions, but the one study I'm going to highlight for the purposes of this talk concerns a topic that really is a challenge to mental health clinicians, and that's the question of relapse. So if you look at relapse in the context of sort of one of the most debilitating mental illnesses, schizophrenia, this is an illness that is common in about 1% of the world's population, so affects millions of people. But what is really challenging about it is that even for people who are under treatment, for these schizophrenia patients, there are studies that say that about 80% of people can relapse in about a 5 years time frame. But the clinicians really struggle because their knowledge of relapse is retrospective, meaning that they get to know that the relapse has happened after the relapse has happened, which typically is the patient comes back to the doctor and they have elevated or exacerbated symptoms, and they have to be immediately hospitalized so that the symptoms can subside. So the clinicians on our team, as a part of the action research paradigm, were interested in the question because they wanted to see if the status quo can be changed. And changing the status quo here would mean that the clinicians are able to see if there are any signals or early warning signs in the social media data of these patients that can kind of make their knowledge of relapse to be more proactive rather than retrospective. And this can have a lot of impact on the treatment and interventions that they provide to their patients if they can understand the risk of relapse early. For instance, they can change the medication, they can change the therapy, and so on. So to answer this question of whether we can predict relapse with social media, here we are reporting on analysis that spanned about a little over 100 early psychosis patients. So this is an ongoing study. At that point in time, we had this many patients, about half of them had experienced a relapse. And here relapse is defined as a hospitalization due to exacerbated symptoms in schizophrenia spectrum disorders. So for these patients, we collected their full archives of Facebook data that the patients voluntarily consented to. This allowed us access to very rich longitudinal data at the patient level that we could use to predict the risk of relapse. So let me tell you a little bit about sort of the modeling considerations in our work. And these considerations were guided through discussions with our clinical collaborators as a part of the action research framework. So the first consideration was that we found supervised machine learning approaches that would sort of distinguish between people who relapse and people who don't relapse were actually not suitable in our case. And the reason is, relapse is an incredibly multifactorial event, meaning that they actually manifest in different ways in different people. So in a sense, they're heavily associated with clinical heterogeneity. So supervised learning approaches that basically get at group level differences is not useful to capture that kind of heterogeneity in patients. The second challenge was that there are actually no true positives or true negatives in this setup, which you would need for a supervised machine learning framework. That's because any individual actually has a non-zero likelihood of relapse at any point in time. And then the other important consideration is that relapse is actually a pretty rare event if you look at the broader timeline of health of a particular individual. So given these considerations, and to counteract sort of the reality of this data and enhance potential use, and the potential use here being that the clinician wasn't interested in just a classifier that would distinguish between people who relapse or not, but rather they're interested that given a certain patient, what is the likelihood that they're likely to relapse in the next 1 week, in the next 1 month, and so on. So given that potential use, we model the relapse prediction as sort of an anomaly detection problem, where our idea was to look at sort of the longitudinal patterns of activities and behaviors that we can get for a specific patient from their social media feeds, and then identify whether there are aberrations in those behaviors that deviated from that same person's baseline. So we constructed two types of data here. So periods of health for every patient. These were essentially 1 to 3 months of data where there was no relapse. And then periods of relapse, which were a month of their Facebook data prior to the hospitalization. And these we were calling anomalies in our framework. So the question is, what did we find? And I'm going to highlight two specific metrics that are particularly insightful here, and that is specificity and sensitivity. Here, specificity means relapses that were correctly predicted to be relapses. And we notice that the specificity of our model is pretty good. We can predict relapses to be relapses in about 79% of the cases. But where our models don't do so well on is the metric of sensitivity. So there are a lot of cases where our model thinks that this should be a period of relapse in a specific patient, but in our ground truth data, this is marked as a healthy period. So the action research framework allowed us to unpack why do we see this difference in performance on one metric versus the other, and how can we potentially unpack those causes of the whys behind model performance that could enhance potential use of the models in real world contexts. So for this, we conducted an error analysis. Essentially, we appropriated an unused source of data that we had access to, and these are clinical chart reviews. So these are essentially unstructured notes that are written down by a clinician following their appointment with a specific patient. So luckily, for about half of the false negative time periods where our model predicted a time period to be a relapse, but in reality, they were periods of relative health. For half of them, we did have some data that we could glean from these chart reviews in the patient's medical record. And then what did we find? We found that actually for about 90% of those cases where there was some data, the clinician did note in the chart reviews that the patient had experienced some psychotic symptoms. But given the subjectivity that exists in the mental health evaluation and mental health treatment field, at that point in time, this clinician did not assess the symptoms to be severe enough that would warrant a hospitalization. But this context was missing in the way we were constructing ground truth data in our models. And that's why in the ground truth data, it shows up as a healthy period. But our model that learns from the social media data or Facebook data of these patients does note some early warning markers of these psychotic symptoms that were noted by the clinicians as well. And that is why, based on those symptoms, it is assessed this particular person to be at risk of relapse in these cases. So essentially, what are the takeaways of this research? Some of the challenges that we discussed early on in this field, such as agency and power, unintended negative consequences, our goal was to see how these kinds of action research paradigms where we collaborate with these clinicians can allow us to overcome some of those challenges. And we find that indeed some of those approaches have allowed us to get at the whys of the performance of these models. So we didn't just incorporate their feedback in the types of modeling decisions we made in this work, but at the same time, we were also able to identify when does this model work, when does it not work, and when it doesn't work, why is it not working? The other aspect of this work is also this aspect of personalized approaches. So the modeling decisions that we made as a part of our action research paradigm are meant to be personalized to the specific patient whose data we are looking at. And this is really important to inform clinical decision making. It is important if you want to connect specific people with specific kinds of culturally and context sensitive mental health help or interventions. What our work shows us is that when we partner in an iterative way with these stakeholders, we can begin to develop those kinds of approaches. All right, so now let's move on to our second case study. And this case study, like I mentioned earlier, it is at the scope of the population. Here we were collaborating with the Centers for Disease Control and Prevention in the US, and it's also based on a 2 year long collaboration with the CDC, where our central goal has been to inform suicide prevention efforts, where social media data and other online data could be used in conjunction with other kinds of public health signals that organizations like CDC are already harnessing. So our motivation here was that, in the last 20 years, the rates of suicide in the U.S. population, they have been monotonically increasing across pretty much all demographic groups. So of course, there is the question of why that is happening, but an equally important question is that it's important to figure out how much of an increase are we seeing year to year, and how much can we expect to see prospectively in the next year. So to answer that question, as you can imagine, we need real-time data. We need data from now so that we can make a forecasting of what can happen in the next week or month or year. But unfortunately, such real-time information on suicide fatality trends is really missing right now in public health based suicide surveillance work. In fact, if you look at the CDC, right now, CDC, this is June 2021, the latest data that CDC has access to is from December 2019. So there is a 1 to 2 year gap, depending upon when the data is collected, on national statistics on suicide rates. So organizations like the CDC really want access to these types of data because they need to make budgetary decisions. They need to deploy interventions or adapt policies that can, improve access to care, or designing programs for suicide prevention as well. So to address this gap in this collaborative research, we wanted to develop sort of a first of its kind machine learning model that could allow us to estimate weekly suicide fatalities in the US in near real time. So, what did we actually do? So, our goal here was to build a machine learning framework that would predict weekly suicide deaths in real time by combining together different types of data. So, the types of data that we considered here have a real time aspect to them, and these included, let's say, novel health services administrative data, such as visits that were made to an emergency room because of a suicide related reason, calls that were made on the National Suicide Prevention Lifeline in the US, or calls that were made on the Poison Center Control Lifeline because of a substance overdose. And then we had other kinds of online real time data. These included social media data from Twitter, Reddit, Tumblr, and search engine trends such as Google search trends. And then we had a couple of non-real-time data as well that included economic data and meteorological data. Our hypothesis for using all these data sources was that, when we combine information from these varied sources, it would enhance the accuracy of estimates of suicide deaths more than we can do with any individual data source alone. And it would enable sort of estimating trends of suicide fatalities much better, that can actually practically be useful to inform public health activities by organizations like the CDC. So with that goal in mind, again, we adopted this action research framework to come up with the right modeling decision for this work. So here is our overall architecture. So at a high level, there were two phases in this work, in this modeling architecture. At first, we focused on finding the best predictor of the weekly number of suicide fatalities for any given data source. So individual models were trained using a training and validation approach. So first we trained for any given data source, we trained a model based on the time series data of that source and the weekly number of suicide fatalities. And then we find it allowed us to finally output sort of a series of intermediate results, essentially predictions of weekly suicide fatalities at any given week of interest for each of these data sources. And then what we did is we had a second phase that involved combining these individual estimates of suicide using a deep neural network. And that would eventually give us a single estimate of weekly suicide fatalities that would kind of incorporate the signals from all these data sources. So the question is, how did this model perform, right? So overall, we find that when we combine different data sources, we do better expectedly than models that used a single data source alone. But importantly, I want you to pay attention to this very last row on this table, which is the all data sources. So all data sources ensemble that combines all of the signals together, we find that it outperforms obviously the best performing models for each of the single individual data sources. But importantly, it also outperforms a baseline model. And here, a baseline model is essentially a seasonality adjusted time series forecasting model, autoregressive model that estimates, future rates of suicide based on historical suicide fatality data. More specifically, we find that when we combine these data sources together, first of all, we do very well in predicting the trend of the suicide deaths, and that you could see by looking at the high correlation coefficient here. But also, these models allow us to have a pretty good estimate of the absolute number of suicide deaths, and that you could see by looking at any of the root mean squared error or mean absolute percent error metrics, where we find that this ensemble reduces error around weekly estimates by approximately half. But what is finally the most interesting piece of information here is about suicide rates. So the ground truth here for this specific year, this was 2019, the ground truth was about 14.47 deaths that were attributed to suicide per 100,000 of the US population. And if you look at the equivalent estimated number, when we combine these data sources together, that is 14.4, meaning that we only have an error of under 1% for these models. All right, so what can we take away from this research? So a motivation that I mentioned early on in the second case study was that currently we don't have established way to gather real-time national information on suicide trends. And that is super important for timely suicide prevention efforts. So what we did here is we combined signals from both online and offline contexts together. So essentially, you can also think of them as sort of novel data sources like web and social media data, and also traditional public health data sources, such as access to healthcare or different pathways of care. And then when we did that combination or ensembling, we were able to achieve a pretty good estimate of suicide in a near real-time fashion. But the real strength here and the takeaway here is the strength that we get by combining different data sources together instead of relying on a single data source. So when we combine data sources, what we find is that it allows us to overcome maybe the underlying biases, the idiosyncrasies, and unique characteristics of any single data source. And that is very important because people have different pathways of mental health care. Some people are going to talk about their mental health on social media. Some other people are going to be picking up the phone and calling the crisis helpline. Some other people may be showing up to a doctor to get help from their, suicidal thoughts. But probably there isn't a lot of overlap between these different pathways because the person who calls up the National Suicide Prevention Helpline is probably never going to talk about it on social media. And the person who talks about it on social media is probably very skeptical about formal mental health help and is never going to show up in the emergency room to get help. But by looking at all these different data sources, we are able to take a more robust approach. We are able to harness the signals that spans a much richer and diverse population and captures these different pathways of care in order to come up with estimates of suicide deaths. So at the moment, these models are currently being considered to be deployed at the CDC, but there are also kind of practical questions that need to be answered on that front, including how can we use the outcomes of these models to predict in the future when there's likely to be an uptick in suicide fatalities, and the kinds of measures that need to be adopted to counter that. All right, so at this point, I'll begin to wrap up our conversation here today, and I'll highlight a bit about sort of the path forward. So far, hopefully you have a sense of the possible computational uses of social media data for mental health. And hopefully you got a glimpse of various collaborative action research paradigms that you could use to provide us with a viable approach to translate some of the potential uses of social media and mental health in real world context, and also what could be some potential solutions for that. But I would note that these are far from being complete. And actually, I do recognize that there are a lot of unanswered questions in this field. The first one is about real world translation, right? And this came up when we were talking about the first case study on relapse, where we saw that we do pretty well in terms of specificity metrics, but not so much in terms of sensitivity. So the question comes up is that, what level of algorithmic performance do we need for real world translation? And beyond sort of specific models or specific context, this question is really important because machine learning models are not perfect, right? They are going to inherently have some uncertainty in them. So the question becomes, how can we support graceful failures when either our data or our models cannot stand up to the potential use case? Importantly, one approach that clinicians take throughout the world is the Hippocratic Oath that they will do no harm to their patients. And how do we imbibe such values within the models that we are building? The second piece that we need to realize about real world translation is that, when we think about having these models and bringing these models into the real world, we have to realize that these models cannot exist in a vacuum because interventions for mental health do not exist in a vacuum. They are part of a socially situated and structurally influenced pathway of care, right? So we need to think about how do these algorithms or these insights from these novel data sources fit in within the existing ecology of mental health treatment. Then there are questions about the future of mental health work. I mean, obviously we are talking about a new source of data could be used, that could be used by clinicians or could be used by public health workers. But as you can imagine, these individuals are not trained in machine learning or algorithms or how to interpret outcomes of big data analysis. So we are talking about either a form of skill acquisition, obviously that will create a lot of burden to the clinician, or maybe we are thinking about sort of a set of new types of roles of people in mental health work who would essentially be interfacing between the data outcomes and what the clinician does. But in building that buffer or that middle layer in mental health work, we have to think about how do we then balance agency and automation, because we don't want to take away the agency from the clinicians, and eventually we do want a human to make important decision about another human's life instead of an algorithm. So how do we then think about these models that can allow sort of this sharing of knowledge between machines and humans and allow machines and humans to work together? What kind of trust uh, needs to happen in these kinds of human machine collaborations? And obviously questions of interpretability and transparency come up when we talk about these algorithms. And then there are questions of social justice, a question that has been at the top of our minds in the last 1 year. One thing we have to realize is that people who are suffering from mental illness are already marginalized. They're already in low resource communities. So what we want to make sure is that the technologies and the algorithms we are building actually support these disproportionately vulnerable and marginalized people. And one way we can do that is by thinking about algorithms that are sensitive to people's cultural identities and their unique needs and desires. We know that identity influences how people access mental health care, whether it is their gender identity, their race or ethnicity. And then that means how can we build these algorithms that are respectful and sensitive to those dimensions? And finally, I would remind us sort of the broader picture here, that we are not just aiming to develop the most accurate algorithm and bringing in computational techniques to bear on a societal challenge like mental health. Obviously, accurate algorithms are important here, but it's not just a technical approach that is being fit into a social problem, but rather we are tackling a socio-technical problem here. And it's a socio-technical problem because of the social piece here. And as the code in the slide shows, many people have mistrust in existing mental health systems across the world. And we do not want technologies and these algorithms or data sources to become yet another source of distrusts. So the question is, how can we humanize our approaches so that people feel, different stakeholders feel, whether clinicians, patients, public health workers, that they have an opportunity to work with each other to define what may be the best strategy forward instead of the algorithm making those decisions. So essentially, while I told you about two collaborative and participatory approaches that use the action research theoretical lens to go about sort of tackling some of the existing pitfalls in the current field and make research more translatable in the real world, um, we need to do more research to identify what is the best way to represent the different human stakeholders in the ecology of mental health treatment and mental health prevention. So that brings me to the end of this talk. I would like to thank all my students, my collaborators, and of course the sponsors without whom this work wouldn't be possible. Thank you very much for listening. And I think I have a few minutes for questions.
Yeah, thank you. Yeah, we have plenty of time for questions. Thanks for really insightful, really interesting talk. Yeah, I have some comments and questions, but let's look at maybe we'll have some other questions. Yeah,
Sure.
we already have a question from Nora. Nora, do you want to ask it yourself or? Yeah.
Yeah, sure. Thank you so much for this great talk. I'm not, I don't do research in a clinical research or any health-related research, but I'm a political scientist, and I am always fascinated how much data you guys have, and you make very strong kind of inference from the digital trace data. I don't know how you do it, but for like digital trace data is not really informative so far for political outcomes. We barely can predict voting behavior, even with like very like a fine-grained Twitter data. But yeah, I was having this like general questions about the potential of digital trace data in the future. And Yuri, thank you so much. Yeah, yeah, this sensors is all fascinating, using it in your research. And I was just thinking, so far, and we had this conversation yesterday, that very few social outcomes can be predicted from social digital trace data. And what is your kind of thinking about what can change this situation? I mean, like, what can be a driver of making digital trace data more informative for making like clinical decisions specific? Thank you.
Yeah, no, that's a super important question. And I do agree with you that social media is not, or digital trace data on the internet, it's not magic, right? It cannot predict everything. It would have been nice if it could, but we have seen repeatedly, like, for instance, you were mentioning in political science how bad some of these models are in predicting election outcomes, right? So a good example of that is actually the previous, the 2016 presidential elections in the US, where all models were wrong. So, the interesting point here is sort of the underlying question, or the specific social question that we are tackling. And the reason we do pretty well when it comes to mental health, or pretty much sort of, questions of psychological well-being, is that there is a strong link between the words that we use and the way we express themselves and how we are feeling. And because of that reason, we are able to do a good job in understanding people's underlying mental health concerns, which is very different from voting behaviors, because I could say something on Twitter and actually vote completely differently in the real world. So there is this gap between offline and online. So I think that brings me to the second part of your question, which is, how do we make digital trace data more useful? I really think the potential to do that is by thinking about bringing together different kinds of data together. And we saw some examples of that in the work with the CDC, where we combined, online data with offline data, such as what is happening with people's access to mental health care in the offline world. And I think there are opportunities like that for other kinds of social questions, because to be honest, social media data is just one lens that we have to look at people's behavior. It is a useful lens, but in many cases, it is also equally important to look at behaviors that happen elsewhere. And by looking at other kinds of data on behaviors, offline data, survey data, or even sort of digital traces of other kinds, such as wearables, smartphone use, all of those are valuable signals when brought together, can be immensely helpful to better understand social phenomena.
Thank you so much.
Yeah,
Mhm. Thank you
thank
for the
you.
question.
Yeah, so I see that Sophia also has a question. Sophia, please.
Sangam also has a question in the chat.
Yeah, sorry. Yeah, so Sangam, would you like to ask it yourself?
Yeah, I can ask myself. Thank you, Munmun, for a very interesting talk on the subject. Actually, I don't come from this particular area of research. I come from primarily telecommunication and deal with the some of the products which are like zero emissions product, right? So my question was more targeted towards the usage of machine learning techniques that you briefly talked about in the architecture that you showed. So I was just interested in kind of trying to find out what sort of base classifiers you chose for in the ensemble method, and what was the reason for choosing those. So was there a particular reason? Because there are a set of machine learning methods that you could probably use there, like bagging could be one, decision tree, then the linear regression could also be a part of it. So I just wanted to kind of understand this part. Thank you.
Sure. So I glossed over that detail, but essentially what we did is we looked at sort of all major families of machine learning algorithms, because going into the project, we didn't quite have a very good sense of which models will be good for which sources of data, because the underlying characteristics of each data source was very, very different. So we expected that different models would work better for different data sources. So we actually adopted an ensemble approach. So we, even for every single data source, we trained a number of different models, and we picked the models using voting and bagging and boosting to identify the one that performs the best. And indeed, we did find that for different data sources, the optimal models were different from each other. And the reason was, one of our goals here was sort of the eventual potential use here. And I highlighted that several times in the talk, is it's important to keep that in mind. So in a different project, our decisions to choose different models may have been different, because maybe we care about interpretability or being able to look under the hood about what is going on, or what are the signals that are being picked up by these models. But in this case, we kind of wanted to take a much more comprehensive approach, because our collaborators from the CDC said that we don't quite care about, what is exactly happening under the hood, but we want the most accurate model that is possible. So give us that model that you can get. And that was the reason we kind of had this broad swath of models we looked at in this work in order to find the most optimal one. But again, I mean, if it was a different project, we would have made a different decision on the types of models that we consider. But that's basically our underlying philosophy when we go about these projects, to think about what is it that we want to do. Do we want to understand what leads to a certain outcome, in which case interpretability is important, or do we want to optimize for the eventual outcome, make the best possible model that could be built, and depending upon that we choose models.
So if I just have to kind of summarize what you said just now, it is something like based on the outcome, the decision was taken to kind of go with the ensemble method, right?
That's right. Yeah.
Okay. Okay. Thank you so much.
Thank you for the question.
Thank you. So, Sophia, I guess, right now.
Thank you very much for presentation. It was very, very, very interesting. I have two questions. The first one about anomaly detection. So in your studies, you are very often trying to identify some anomalies, very rare events. And I would like you maybe to give some short guidance how to maybe how to make your research in order to identify such very rare patterns based on social media data, because in this social media data, they usually contain a lot of different information, which might be very noisy. And maybe my second question, it would be about social isolation. So you're studying psychological well-being, and we know that individuals with high levels of depression, they often might be social isolated, and they might not provide enough signals in social media. And maybe it is also a signal, but still it might be also difficult to identify whether these individuals really in a difficult situation. How do you deal with such cases? Thank you.
Thank you for the question. So if I understood it correctly, you are interested in sort of how do we kind of get the useful signals out of sort of the world of noise that exists in social media data. That was the first part of the question. And the second part was, what does it mean when there is actually no social media data? So people who are socially isolated, right? So really good questions. So first of all, we actually embrace the noise in the social media data, because to be honest, I think noise is still some kind of a signal when it comes to questions of mental health. So for instance, if you look at people with schizophrenia, if you don't see a coherent topic or set of topics that are persistent in someone's conversation, that is actually an important signal. If they are being haphazard in their communication, if they're not typing properly, if they're not, constructing ideas in a coherent fashion, those kinds of signals actually are very strong predictors of relapse or an exacerbation of symptoms in early psychosis. So we look at the entirety of things. We even look at stop words, because they say a great deal about people's underlying psychologies. A use of stop words or use of function words can indicate that people are paying attention to their writing, to things around them, and that means self-consciousness, which is a good thing for mental health. So that's how we deal with the question of noise. In terms of when people don't use social media, that is a really important question, because like you said, people with very high levels of mental illness may not be in a position to use social media. And that we do see in our patient data, when for weeks and months together, we see like blank, like no social media activity at all. And the way we use that information is actually to also use that as a feature in our model. So like levels of activity, even presence or absence of activity, is actually a very good signal for some of our predictions in the patient population. Of course, it's hard when you don't know about the clinical or diagnostic status of an individual, because people go away from social media for all kinds of reasons. It's not necessarily for exacerbated mental health, right? People go on breaks. But this information is particularly helpful for the patient population. So for instance, in the relapse work, we could see that for a lot of people, there was a decline in their levels of social media use for some people, they stopped using social media altogether. And that was still a valuable information and signal that we could use in our work. But in other works, again, I would go back to this previous connection I made about using different types of data together, so offline and online data together. And some other work that I didn't have a chance to talk about today, what we have seen is that when we see a non-use of social media, we can maybe look to other types of data of this person and begin to triangulate what might be happening in their lives. So maybe you can look at their smartphone use data, you can look at their wearable data, and get a sense that this person maybe was having a difficult episode during this time. So that's why they are not on social media. So those kinds of triangulations and those kinds of opportunities to bring together different types of data to sort of fill in the blind spots is going to be really important for this kind of work to have potential for use in the real world.
Thank you very much.
Thank you.
Great. So do we have some other questions? Yeah, Yuri.
Thank you very much for your talk, Moon. That was inspiring. I have.
I'm finding it a little hard to hear you.
Yeah. Can you? You're really like you're not really loud. Yeah.
Okay. Do you hear me well now?
Right now it's better.
Better. Okay.
Yeah.
Thanks for your amazing talk. I have one question, maybe come from a very, very simplified view on how a different mental illness can be detected using digital trace data, different sources of this data. So, for example, using a social media like Twitter, Facebook, or other similar platforms, we know that we can monitor like two main dimensions of people behavior. So first one is language use. What people post, what do they say, how do they express themselves? And second is dynamics of their social interactions. With whom do they interact, comment, like, and so on. So we can identify these two major dimensions of behavior, language use, and dynamics of social interactions. So, and what do you think, which dimension is more indicative of affective disorders, such as depression, anxiety, this mood spectrum disorders? Which indicators or which biomarkers based on this should have higher discriminatory power and predictive power?
So that's a really good question. So what we have seen is, we try to use all possible signals. We don't pick and choose because, there are personalized differences, of course, right? Some people's better signatures come up in their social interactions, some other people in the words that they use. And given that we are interested in building these personalized models, we take all of these signals into our account and then let models pick up the most valuable ones. So that is one strategy. But one thing that we have seen more as a more direct answer to your question about discriminatory power is that the utility of these different classes of signal, that really varies by the platform that you're looking at. So in some of our very early works where we kind of replicated the studies in different social media platforms, particularly Twitter and Facebook, we did find that across these two classes of signals, there were differences across platforms. So I don't know how much you can guess, but for Twitter, we did find that actually the language signals were more valuable. The words that people were using, such as sentiment, people's moods, function word use, and so on, were really valuable. But for Facebook, we actually found that their social interactions were more valuable in predicting some of these mood disorders like depression. And then we conjectured why that might be the case. And our conjecture said that, Facebook in some ways is a highly curated platform, right? I mean, people are very conscious about the specific postings that they write, the specific ways that they phrase it. It is also a place where our social networks in many ways reflect our offline social networks, as in we are friends with people we know in the offline world. But Twitter is very different, right? Twitter is a broadcasting platform. It's not so much about the social interaction. Most people that we follow or follow us are actually people we have never met in the offline world and probably are never going to meet in the future as well. So that platform is less about who we interact with, but rather what we are saying. But Facebook is different. Its norms are around social interaction. I share something because I want certain people in my social network to know about something, and I heavily curate that. So those norm differences and the affordances of platforms play into how people express themselves and use these platforms for their intent and goals. And that trickles down to impacting what signals come to be useful for these questions. So in general, because people don't post as much negative stuff on Facebook, they're heavily curated, we don't find language to be as useful. But social interactions are super valuable in the context of Facebook, such as liking behaviors, commenting behaviors, because that indicates if people have access to social capital or social support from their networks or not. But talking of Twitter, the words really mean a lot, and the way people express themselves. That's what I have. Thanks.
Thanks. Actually, I have a couple more questions. If nobody have other questions, I can.
Yes, that Nora also wanted to ask something.
Yeah, actually, it's kind of like a technical question about your model about the suicide. You had, I saw that you excluded variables related to economics and meteorology, right, from your model. Did you make the decision because they didn't perform well, or there were some other factors? Thank you.
Yeah, so we excluded that because they didn't quite perform well, which, kind of really puzzled us for a while, because there is a lot of research that says that when you have poor macroeconomic indicators such as unemployment and so on, people's mental health worsens. And these are like established findings, but we didn't quite see those signals helping us. And some of the reasons that we thought about is kind of, it depends upon what kind of macroeconomic indicators also you look at. Like if you look at the stock market indicators, in the last decade until the pandemic hit, the stock market prices were increasing. Like Dow was increasing, NASDAQ was increasing, but look at the rates of suicide in the US. They were increasing too. So they should have technically, if really economy or at least stock market performance impacted mental health, then we shouldn't have been seeing an increase in suicides, but we have. So that kind of fails to capture, that kind of tells us two things, as maybe not all economic indicators are useful, definitely not stock market, because honestly, many people are not investing in the stock market, right? In fact, many of the people who are adversely impacted by poor mental health, they are from low resource environments, they are of low socioeconomic conditions, and they don't have their money in the stock market. So it doesn't matter how the stock market works. These people are struggling, and they are going to struggle and with poor mental health. But even for something like rates of unemployment, real estate related indicators, we didn't find those indicators to be very helpful. And our conjecture there was that, these are very good indicators when we look at the long term. Like if we look at sort of mental health in the last 100 years, 200 years, and we look at economic performance across the world, we'll see a strong inverse relation that, if economy is better, then mental health is also, mental illness is lesser, and so on. But when we are interested in sort of making these real-time week-to-week predictions, that macroeconomic indicators, because they don't change week to week. Unemployment doesn't change week to week. It's a long-term phenomena, right? Or housing, or the fact that manufacturing jobs in the US are declining. These don't happen, these don't change overnight. It's a pattern that takes at least a few years to settle in. And I think that is why those indicators were not helping us in these week-to-week predictions. But that said, I'm not dismissing the utility of these macroeconomic indicators. They are, if you want to kind of look at mental health trajectories in the longer term. But for a practical use in a week-to-week setting, some of these other signals which do capture smaller variabilities, those were more helpful for us. That's a very good question, by the way.
Yeah, that makes total sense. Yeah, with the time series are really, that's the approach when usually economists take when they are trying to evaluate the effect of economics related variables. Yeah, thank you.
Great. So we have another question from Ksenia this time. Ksenia.
Oh, thank you so much for the talk. And my question is mostly about the use of these methods that you presented. So you, I've noticed that two ways, like to benefit the society, so like to predicting what's going on with society in terms of like suicides and stuff like that, or benefiting the concrete patients, like kind of warning the clinicians that they might have like some bad outcomes in the future. But kind of in Russia, we right now see, for example, requests from the authority for some kind of like not machine learning, but kind of this research like that to try to identify, for example, recently we have several mass shootings in the schools and stuff like that. So in the very super simplified approach, the authority tell, okay, let's scroll all those pages in this Facebook or Russian analogous of Facebook here, and they ask like teachers to do this to identify the concrete people who probably at risk of committing something like that. So the two questions like this. So like in this case, this study wouldn't exactly benefit these particular people, especially because there might be false positives and a lot of kind of stuff like this. So the two questions, do you see any kind of request like this in the States, like request for this from the public and authority? How do you deal with this? And any kind of your opinion about this as a possible future like line of the research?
Yeah, thank you for this excellent question that, there are so many ethical challenges around that, right? You're right in that it can be valuable to prevent mass shootings, to identify people who might be homicidal. But again, I mean, what do you do with false positives, right? You don't want to live in a world where people are jailed or arrested before a crime is committed. But at the same time, we want to prevent crimes from happening for the overall well-being. So it's tricky, and the ethical questions are really hard there. I personally haven't had requests from authorities to for collecting this kind of information, but I do know that there are some sentiment, again, sometimes this aligns with specific political ideologies and whatnot. A lot of people, mass shootings are a huge problem in the US, right? I mean, gun violence is a huge problem, and it's a very politically charged issue here, depending upon, there are two dominant political ideologies depending upon what people identify with. Some people say that, for gun violences happen, these shooting events happen because of people with poor mental health. And then the other camp says that they happen, no, because people have access to guns. And if you look at a country like Japan, where, mental health is a significant challenge, you don't see gun violence incidents like in the US anywhere close. That's because getting access to a gun is incredibly hard in Japan. So, I mean, there are people who try to correlate that. Yeah, if we can find people who have mental illness, then we will be able to address the gun violence problem. And that is sort of a political ideology that a lot of people maintain. So as such, I haven't received such requests. But that said, I did have, there are instances where there was, people who wanted access to these kinds of algorithms or data, and I felt very uncomfortable. So I'm going to give a couple of examples, one of which was an insurance company who were interested in kind of, looking at the social media data and making these inferences about their policyholders. And they, at least to me, they said that, no, we want to do this because we want to reduce the insurance premiums of our customers who are in good health, or maybe people who are struggling with mental health. We want to give them more opportunities to healthcare. But I was skeptical because because of the history of how insurance companies operate, and I was worried that this might marginalize and disadvantage people with mental illness because their premiums might go up. The insurance premiums might go up for those individuals. So I didn't pursue that collaboration at that point in time. So that was one instance. There were other instances that primarily came from the military world as a way to kind of identify PTSD and similar concerns in the military. And I felt skeptical about that as well, because, if you talk about the military, like, if authorities want data from them, they have to give access to their data. So there isn't anything like an informed consent where I cannot choose to not share my data because I don't want to. That option is not there. And I feel like not having that option can be a difficult question for human rights, right? So there are definitely some questionable uses of the use of these algorithms. And I have seen a couple of examples of that. But yeah, we have to keep on coming to this question going forward, because to be honest, there are many actors like that who have a vested interest in the outcomes of these algorithms. Or maybe there are people who do have a good intention to use these algorithms, but it is just ethically really complicated. How would you go about doing that?
Thank you so much. And thank you so much for the examples. Thanks.
Okay, well, do we have some other questions? Well, in this case, I guess that Yuri wanted to ask something else, right?
Yes, thanks, Lisa. I have a couple of questions with regards to this study about relapse in schizophrenia, and second one about general prediction of mental illness by language use. Let me start maybe with the second one. I know that the most methods for detection of depression or affective disorders by language are dictionary based. So that simply means that we have some dictionary, some vocabulary with the words which are indicative that something is wrong with the person. And I'm wondering, in the changing world, for example, if the dictionary was composed, during, let's say, from 2010 to 2019. So how well this dictionary will work during the 2020, and how the changing world, like changing the context, changing the overall social situation, will affect that language which people use, and how well these dictionary-based methods can work and predict depression, anxiety, when the world is become a bit different.
Yeah, no, that's an excellent question. So that is the reason why in our work, we use both dictionary and non-dictionary approaches for language modeling. We don't solely rely on dictionaries for this very reason, that dictionaries change, and what could be indicative of mental health at a certain point in time may not be the case later on. So in our work, we look at, some dictionary stuff, but we also look at sort of function word use, which are, persistent words like articles and prepositions and pronouns and so forth, which, do not change over time. They're persistent in order to, you need to use them to construct a sentence. But also we look at other sophisticated approaches such as topic models. We look at more modern techniques like bag of words. We look at word embedding models and so on, so that we are not fixated on specific words, but with word embeddings, we can look at other words that are semantically close to this word and could be potentially used as alternatives. So we use all of those techniques as a way to expand the kinds of way we look at language models. And oftentimes we don't look at single words. We often look at the context as well. So in our work, we have used methods such as sentence embeddings as well, specific types of framings that people use. So those all have been kind of valuable signals for us in this work. For schizophrenia in particular, other kinds of approaches are meaningful too, such as readability, right? And then a kind of coherency of topics across different postings. And those are all signals that do not necessarily need whether or not a specific word is used, but sort of the patterns of use of a collection of words or phrases. And those are really helpful. But in general, for a field like this, you constantly have to be tinkering with the features that go into the models. And a good example of that was the Google flu trends, which did not do that, right? So the searches on flu that were, the searches that were indicative of the flu in, let's say, 2009 on Google were not the same as what they were in 2011. And that's why, if you know about the history of the Google flu trends platform, their predictions became worse over the years. So in any time we think about these models and we want to deploy them in the real world, it is important to look beyond dictionaries into these other, whatever is the cutting edge technique in language models, but at the same time also constantly keep an open mind about adapting them, because new platforms come, new norms emerge, people's usage and purposes of use of these platforms change. So there is a constant sort of catch up you need to do to update the models going forward.
Yeah, thanks.
Mm-hmm.
And second question, maybe it's more clarification question with regards to the prediction of schizophrenia relapses. So as far as I understood, you used only social media data, right?
That is right. Mm-hmm.
Yeah, and I saw that you have a couple of publications in collaboration with John Torus, and yeah, he developed this digital phenotyping methodologies, which basically integrate social media data with other sources of data, which collected with the smartphone, with inbuilt sensors and even general like device use statistics. So, and I think that this approach should be more powerful for detecting such things as schizophrenia relapses and onset of other health conditions, mental health conditions. So, and my question, why did you limit yourself in using only social media data for relapse prediction?
Yeah, so there are two parts to that answer. The first one is that in this context, in the context of a Thrive project, we are primarily interested in data that can be passively gathered without too much burden on the patient. And that is the reason we decided not to necessarily use wearable or smartphone data, because you have to have an app running on the person's smartphone. You can now do long-term studies. For a lot of these mental health concerns, you want rich longitudinal data. Yes, a month-long study and data could be helpful, but you may not actually see a relapse in that period. We wanted to kind of see longer term trends, and by looking at social media data, like people have been using platforms like Facebook for 10 plus years now, right? So that gives you that long-term view. So if you are interested in looking at treatment trajectory or illness trajectory, you do want to have that longitudinal data. And that is the reason We wanted to use social media also because people are already using these platforms. You don't have to put any extra app. You don't have to do anything fancy. They are on this platform. They have been using these platforms. You just have to get their consent to access that data. So we wanted to keep the burden minimum because, you know, these are vulnerable patients. They're struggling with their mental illness, and burden was an important issue. So if that, for that reason, we were looking at social media, but actually we have other projects as a part of Thrive where we are looking at a range of different social media platforms, not just Facebook. So we are actually gathering data from Facebook, Twitter, Instagram, Tumblr, Reddit, and also their Google searches and browsing behaviors. So we are kind of getting a swath of their web activities and putting it all together. But that said, there are other contexts where putting together social media and other kinds of digital trace data can be helpful. And we have done that in some other work that I didn't get a chance to speak about today, and that is around workplace well-being. So in that project, we were interested to look at how digital trace data that comes from different sources can allow us to get a better sense of stress, anxiety, and other challenges people experience at the workplace, and also workplace performance, job performance related measures. And there we had 5 different sensors that we combined together, one of which was social media, of course, but also we had wearable data, we had smartphone application use data, we had a Bluetooth sensor that assessed physical co-location, and then we had a GPS data that looked at their geographic location. And we found that many interesting, valuable signals can actually come when we combine these data sources together for that specific problem space. But this was not a clinical population, and this was a largely healthy population, but we are interested in questions of workplace well-being. So it made sense. This was a tech-savvy population already. A lot of them, obviously, pretty much everybody had smartphones, pretty much everybody was wearing some kind of a wearable. So it was not an additional burden on them, and we felt okay to collect that data for that population. So it kind of really depends on the question and the population that you're dealing with. And that, for us, it motivates the kinds of data that we collect.
Great. Thank you. So do we have some other questions? If not, I just wanted to make a small comment and then one really basic question. So I just wanted to comment on the really, like, for me, this was really interesting and important what you've said about this case when you worked alongside with clinicians, and you saw that sometimes actually your model was better, was like less subjective and more objective, and predicted these relapses. I think that it's important because right now people are like, before we all thought that, well, now we have all this objective data and we can overcome our human errors, right? But after that, we saw that these algorithms, they are also, they are based on this biased data. So that's why they are also biased. But in this case, this is a great example that, yeah, somehow in some cases, these hopes, they are true. And this also reminded me of the great study. I unfortunately, I don't remember the names of the researchers, but so we all know the study by Emil Durkheim about suicide. So he also treated this suicide like a social fact, like we have suicides and like not suicides, death not by suicides. But after that, there was some there was a study which showed that basically how like it's not some ground truth what's suicide and what's not. So there are some people who decide, who analyze the context. So they decide what can be considered a suicide and what's not. And these decisions, they are influenced by many factors. And that's why it's great that you actually looked at what how these decisions are made. So yeah, this is important to like look at how this target variables are measured. And also a good question about how you told us that this interesting thoughts about the future of this whole field of clinicians' work. So I've never thought about that before, how this research on digital traces, how it could influence the like how this clinicians work, how they the implications for their work. Because actually, yeah, maybe you said about the roles that maybe we need to have some new roles. So I just wanted to ask how these clinicians that you worked with, how they felt about these new opportunities. Like, do they are they afraid that they will be somehow replaced soon with all this artificial intelligence, or they say that it's all nonsense and this doesn't work? So what's the impressions?
So, I have seen like both extremes. Luckily, the people I work with, they are optimistic. They do recognize their limitations in how we diagnose mental illnesses or how we treat, because there's a lot of subjectivity there, and they want to kind of see if technology can help their work. So they don't necessarily are afraid of these algorithms, but rather they see that these algorithms could be an additional source of information that they could use to improve their work. But at the same time, I have met other clinicians who are very skeptical. Sometimes they're worried that we are essentially moving into a future where the things that a clinician used to do will be done by an algorithm. Although that is, to be honest, never possible, because the clinician can assess certain aspects of the illness that an algorithm never can. And then there is some skepticism around sort of AI and its accuracies and its biases and so on. That is also there that we see. So we often say that, the future that we envision is sort of a future in which the human, the clinician, and the algorithm would work together. They would collaborate, with the understanding that both of them have their biases, both of them have their limitation. But the hope is that, when we bring the knowledge of these two different kinds of experts together, we would have a much better understanding and information to make an assessment about a person's mental health, rather than either the human or the algorithm alone.
Yeah, thank you. Yeah, so yeah, I guess that if we don't have any other questions and comments, I believe that this is the right moment to end this session, because this is really positive thing to say. We should work together, with clinicians and artificial intelligence. So yeah, this is really optimistic view. So thanks for your really amazing talk and for the discussion. I believe that it was also great. So you really provoked some really interesting questions. And thanks for your answers. So have a nice day. Have a nice weekend. And yeah, thanks again for joining us. Yeah.
Well, thank you so much for inviting me to this event. And again, I know I just heard that this is the last day of the event, so I appreciate so many people joining, especially across different time zones. And it's a weekend for a lot of people. So thank you for that. And I really enjoyed speaking to you. Thank you for the thoughtful questions. And if you have any other questions or comments from me, you can always email me. I would love to hear from you. Thank you.
Yeah, thanks. Yeah, yeah. Okay, yeah. Thanks a lot.
Thank you very much.
Bye. Bye-bye.
Thank you. Bye.